All right, our speakers are ready. We're going to go ahead and begin our webinar today. Thanking everyone for joining us. I know that we have some more people that will be coming on as I begin our introduction. I'm Marty Peterson, and I'm the host of the webinar today. Our webinar today, we're very excited. The title is Optimizing Diagnostics in Antimicrobial Stewardship Program Implementation, an African Perspective. And this is a live webinar, and we have today live with us Dr. Ombajo. She's an infectious diseases physician at the University of Nairobi and Kenyatta National Hospital in Kenya. So Dr. Ombajo is there on camera, as you can all see her. Very excited to have her with us today. She'll be speaking first with her perspective. And then secondly, will be Dr. Ramsamy. She's a consultant medical microbiologist at the National Health Laboratory Service and the University of KwaZulu-Natal, South Africa. Perfect. Excellent. And I'll be your moderator today. So I have a few slides to take you through that are about disclosures and information related to the continuing education that we're providing today for physicians and pharmacists. So that's very exciting. And the activity itself is supported by an educational grant from bioMérieux. So very generous to have this support and be able to bring these two experts to you live today with their perspective. So just a few slides from me. Disclosures. So because it's CE, we would have to disclose any of our relevant conflicts of interest related to this presentation. And these are our speakers and the people involved in the programming and planning from the Center for Infectious Disease Research and Policy. And we have no relevant conflicts of interest to report. And also to know that the webinar and the slides were peer reviewed by our Executive Director, Christine Moore, physician. The educational activity may contain discussions of published or investigational uses of agents or diagnostics that have not been indicated by the FDA. We do not recommend any of these agents. This is purely educational, and these are opinions expressed through this educational activity. So that's the disclaimer here around responsibility of any newly acquired information that is meant to be educational. Here's our target audience. This information is designed to meet the educational needs of physicians, pharmacists, and clinicians, and people interested in this topic. We have several learning objectives. You should be able to discuss the unique challenges of implementing antimicrobial stewardship programs in Africa, describe the types of diagnostic tools available in the region and how they are utilized to complement antimicrobial stewardship programs, and also how to utilize the laboratory, the microbiology laboratory, and the diagnosis of infectious diseases and surveillance of antimicrobial resistance. So all three important objectives that both of our speakers will be addressing today. And once again, our funding for the educational grant provided by bioMérieux. The CE activity. So I'm going to go through a few slides here of how you can obtain this. Pharmacist CE, ACPE, and you'll be receiving 1.25 contact hours. So the webinar, we will have our speakers and we'll have about 15 minutes of Q&A, so please stay on for that. And then the code will be presented at the end for you to receive this. We have CE for physicians as well from the American Council for Continuing Medical Education, ACCME, as well as the physician continual education. You'll receive 1.25 credit hours as well. And this is where you receive your CE. You go to a website, and I'll be putting this up through a chat box, and this information will be available to you, but it's www.proce.com. They're our CE provider. And if you're watching this live, your deadline is July 23rd to collect your CE. And once again, I'll be giving your attendance code that you will need to obtain this. So that's it for my welcome from the Center for Infectious Disease Research and Policy. This is part of our webinar series and part of our global outreach initiative. So with that, I'm going to welcome Dr. Ombajo to begin. I'll stop sharing my slides and we'll begin her presentation. She's actually going to go off camera to save on bandwidth as she presents live, but she'll be back for the Q&A session. So I'll stop sharing. And Dr. Ramsamy, the two of us can go off camera as well as the presentation occurs.
Good morning or good afternoon, wherever you are. Thank you to CIDRAP for this very kind invitation to present in this session. Loice Ombajo, I'm from the University of Nairobi. I was asked to talk about experiences of AMS in Kenya. We'll touch on issues around AMS, looking at our own clinical experiences, as well as some of the challenges that we may have with issues around diagnostic stewardship. So these are my disclosures, none that are relevant to this presentation. So one of the questions we often ask ourselves as clinicians is what really determines our antimicrobial use? And after many years of working with clinicians at various levels, some of the reasons I've gotten over time include having a very sick patient. And many times, especially in resource-limited settings, we get patients presenting after a long period of illness when they're critically ill. Patients who are in the critical care units often end up on an antibiotic, in almost irrespective of the reason they end up in the critical care unit. Patients who have dirty looking wounds, patient who has a fever or who's deteriorating, or where there is no diagnosis. And a common one is consultant directed, or where the white cell count is high. And the reason I mention this is because these are often targets for training on antimicrobial stewardship and helping clinicians understand that this on their own should not be reasons for antibiotic prescription. So when we look at some of the challenges that we have in developing countries, and you look at the levels at which antimicrobial stewardship should be implemented, if you look at the national level, so in principle, for example, in Kenya, we have a national AMR action plan, we have a national antimicrobial stewardship guideline, but in practice, there isn't enough resource or political commitment towards supporting antimicrobial stewardship and reducing AMR. When you think around questions around quality of medicines, especially in our part of the world, resource-limited settings, the issue of lack of diagnostic facilities or overcrowded health facilities, and these are some of the areas that we'll touch on as we go on with the presentation. When you look at stewardship interventions, the issue of who is willing to be involved in it? How do you engage people to commit time to AMS stewardship are challenges that we have to deal with every day. So looking at the national strategies in Kenya. So one, we have what is called a National Antimicrobial Stewardship Interagency Committee in place with an AMR and AMS focal person at the Ministry of Health. We also have a national action plan that sort of outlines excellent plans on how to implement AMS. We have technical working groups at the Ministry of Health on antimicrobial stewardship, on AMR surveillance, infection prevention control, and public engagement. And very many partners are supporting the Ministry of Health currently. And as I said earlier, part of the lack of political commitment is that even though these are recognized as important, there's no direct funding given to support AMS activities in healthcare facilities, so that most of the work we do is funded by external partners. And there are many initiatives in country that are supporting various sectors and various initiatives around AMS. Engaging animal health partners for One Health approach is very difficult. I'm not sure who's done this well enough. Every time we think AMS, we're sort of focused at what happens in human health facilities. But beginning to work together with our One Health partners is something that we're working on, so that with time, we can actually have a truly One Health approach to reducing AMR. One of the projects that I'm involved in is called the Fleming Fund Country Grant, which was a grant given to support AMR surveillance in countries. So we've partnered with multiple institutions. One of the focus areas is to strengthen the national committee, but also supporting various human health and animal health in the health labs. One of the challenges that we've had is that diagnostic capacity, even just presence of ability to do culture and antimicrobial and antibiotic susceptibility testing is very limited in the country. But over the last several months, we've managed to refurbish and provide resources for a number of labs in country. We've also developed various strategies and guidelines around diagnostic stewardship, around antimicrobial use and consumption, and have trained antimicrobial stewardship committees in several hospitals in the country. So when you think about how to develop labs and how to help labs link to a national surveillance system, the challenge we've seen in countries that each lab sort of, for those that are able to do their work, have their data in-house and nobody else knows what is growing in a particular facility. So there's the issue of setting up a lab information management system and a national data warehouse that allows proper linking of data from each of the labs. We haven't achieved that yet, but it's something that we're really working towards. Also around how to support facilities that do not have capability for culture and antibiotic susceptibility testing to transfer samples to regional labs that are able to support that capacity. Again, that's something that we're trying to work on and have not achieved yet. When we look at diagnostic stewardship, so for us in the clinical area, we want to have data that supports prescription of the right antibiotic. But there's so much else that goes into getting to that point in time. So from the patient, how is a patient evaluated? How do clinicians determine that they actually have an infection, that it's a bacterial infection, and order a diagnostic test in good time? How does that how is that sample collected? How does it arrive to the lab? How is it processed, results reported, and antibiotic susceptibility testing interpreted? And as I said, for many sites, the patients are there, we're able to do clinical evaluation, but that sort of ends there. So it's really around how to support diagnostic stewardship so that antimicrobial stewardship committees can have appropriate data with which to implement some of the activities. One of the other areas we've worked in is around mentorship. So trying to develop a One Health AMR mentorship framework that looks at all the counties in this country and tries to think, how do we link the animal health people to the human health people so that surveillance takes a One Health approach and simple things that can work for both human and animal health. For example, SOPs on sample processing, and then looking at diagnostic stewardship for clinicians. There's been the issue of restricting access to antibiotics and sort of having an aware categorization of antimicrobials in the country. We've done the process of having antibiotics in some categorization. And the issue now really is how do we make sure that there's adherence for categorization. So you may be aware of this already, but we have the access group, watch, and reserve groups. So in many of our facilities, we find that a lot of the reserve groups are used as watch antibiotics. So overuse of carbapenems, of new antibiotics, for example. And it's so important to us that we continue to reserve carbapenems, for example, because beyond carbapenems, we really do not have any of the newer mechanism acting antibiotics, so to speak. So the issue of developing guidelines for general outpatient and inpatient settings is something that we continue to struggle with. So as you know, guidelines should be driven by local data. So it goes back to the issue of what capacity do we have to generate local data and to collate data from various facilities and ensuring sample collection. So the issues of diagnostic stewardship are so key for us, and employing appropriate surveillance strategies. When we look at data on AMR surveillance from Kenya and indeed from many other resource-limited countries, often there's an overestimation of resistance because we're not employing appropriate surveillance strategies. So this is an area that we're thinking about in antimicrobial stewardship. How do we get the best surveillance strategy so that we do not overestimate resistance? So I'll give you some of the experiences we've had in instituting and implementing antimicrobial stewardship in various sectors. So one is an ICU and a neonatal unit. So in one of the critical care units that I support, we had begun to note a lot of AMR. I mean, the incidence of AMR was probably at 50% in the hospital, in the critical care unit. So we came together and thought, what are some of the things that we can do with the little resources that were available? And one of the strategies was to form a dedicated antimicrobial stewardship round. And this one worked closely with pharmacy, with infection prevention and control team, and with the lab team. And what we did is that once a week, we'd go into the critical care unit and review all the antibiotic prescriptions in that unit. Then we'd work with the doctors to review, revise or improve antibiotic use. Many times we'd call doctors and say, you know, your patient is on more antibiotics than they need, or have been on antibiotics for too long, or the dosing is inappropriate. Initially, people didn't like us too much because doctors generally don't like to be called to say something is wrong. But over about a year of doing this, there was a lot of appreciation from the clinical team, and they began to reach out to us and say, you know, I'm struggling with this, what can you do? So with time, there was more and more acceptance of AMS interventions in the critical care unit. And we really worked at truly reserving the reserve antibiotics. And over the period of that year, I'll just share with you data from sort of 2 time points, one in 2017 and one in 2019. So the first one looks at meropenem use. In blue is 2017 and in green is 2019, when we implemented the antimicrobial stewardship board round. And what we noted over that time is that meropenem use went down significantly during that period. The main reason for people using meropenem was the perceived level of resistance to various bacteria isolated. But just working together and working to really make appropriate choices led to a significant reduction in meropenem use. And the question was, is there an identified AMR in this unit? With AMR and resistant to carbapenems, for example, we'd end up using colistin, maybe with tigecycline where appropriate. And over that time, one of the things we noted is the absolutely no use of colistin by the end of the time. And that basically indicated that we had very little AMR. And we want to think that we were the reasons this happened. Maybe there were other reasons that happened. But towards the end of this year, we noted very little AMR organisms isolated in that ICU. So these are simple measures that people can implement in their ICUs that looks at how do we reduce inappropriate use of broad spectrum antibiotics. So this sort of shows the trend with various antibiotics over various quarters. So in blue is meropenem, which was the highest consumption in the critical care unit. That came down significantly. In the first quarter of 2020, COVID came in and the AMS and IPC teams were sort of pulled away from the critical care units to the COVID units, and we started to see an increase in the amount of meropenem that was prescribed in the unit. So we are still hoping to go back to the place where we can truly implement the antimicrobial stewardship rounds. So there are certain critical points that are important to track for any facility. So other than use and consumption, compliance with prescription requirements, AMR, and compliance with IPC measures. And one of the hospitals that we support, again, we looked at antibiotic use prevalence. And what we found is that there was a large percentage of patients who are on antibiotics. So close to 50% of patients in the hospital, the general hospital units, were on antibiotics. And we looked at which units were driving this antibiotic use. So critical care had the highest antibiotic prescription, followed by the surgical units. And based on this data, we went back to the surgical units to review what is it that is driving this antibiotic use. We also found that they were using quite a bit of meropenem. And one of the strategies that we employed was, one, to remove the carbapenems from the surgical pharmacies, so that any prescription of carbapenem required consultation with the ID or clinical pharmacy team. And over time, there was very little carbapenem prescribed in the surgical units. We continue to have challenges with the pediatrics units, which again prescribe a lot of antibiotics and also a lot of broad spectrum antibiotics. And I'll just mention that as we go on. So again, one of the questions is, how do we identify and monitor and control new threats in the critical care units? So one of the units we've worked with to identify new threats was a newborn unit. As you know, neonatal units often represent a very high risk population for AMR. So in this particular newborn unit, even though it was maybe just a 60-bed unit, At any one time, we found up to 180 newborns. So overcrowding is often a big challenge in resource-limited settings. So you'd have neonates sharing incubators, and there are multiple rooms in this unit that had a stable baby room for babies that required multiple feedings, but then mothers would come very often and go back to the general wards and come to the newborn unit. So there was so much opportunity for introduction of resistant bugs into the unit. And when we looked at, again, mortality in this unit, we found that in some of the instances, there was very high mortality, which was concerning for us. What is it that was driving? A lot of this mortality was ascribed to sepsis, and went back to look at all the lab data and say, what is it that's being grown in this unit? So here just shows, again, nosocomial sepsis, a high percentage of deaths was thought to be because of nosocomial infections. And going back to look at our lab data to figure out what is it that was being cultured and what could we do differently. So just to walk you through this, in the blue is Klebsiella pneumonia. And you can see that around the time we're looking at this data, there was quite a bit of Klebsiella being grown, and it went up again towards the end of this period. We also had quite a bit of Serratia in red here. Quite a bit of Serratia was being isolated. And also important is there was a lot of coagulase negative stuff that was being isolated, which goes back to the issue of diagnostic stewardship. How are samples being collected? When were they being collected? How are they being processed? So some of the observations we had in that unit was that there was a lot of room for improvement of the IPC measures, even looking at how many people walk in and out of this neonatal unit, the overcrowding and sharing of incubators by children, by neonates. There's also a need for stronger diagnostic stewardship, and we had to train clinicians and the lab people on how to get samples from neonates, because that's usually quite difficult. And there's a lot of overuse of meropenem, often given as a first agent with long durations of antibiotic administration. So these are areas that we began to address with the unit, just looking at even just controlling movement within the unit and then improving how samples were collected. And with time, we actually controlled the Klebsiella pneumonia outbreak that we had seen in that time. In another hospital, we looked at issues of Candida. We had observed that we're seeing an increase in Candida auris, which is one of the more resistant, very difficult to treat and very difficult to eradicate from hospital environments, and often may be responsible for hospital outbreaks. So we noted that in 2018 to 2019, we're seeing an increase in Candida auris. So we went back to sort of identify these populations and determine what the risk factors were. And some of the things that we found was the issue of invasives that were kept in for too long, sometimes inappropriate environmental cleaning, and overuse of carbapenems. And just working with the IPC team and with the teams in that unit, over a period of about 6 months, we totally controlled the Candida auris outbreak. So these are some of the measures that even in resource-limited settings can actually be employed to try and control for antibiotic use and control emerging AMR or resistant fungal threats. So there are a few other documents that we developed over the last year to try and support some of these initiatives. One is a clinician handbook on appropriate use of microbiologic diagnostic tests. So really just looking at how to support diagnostic stewardship in the country, but also how to conduct surveillance for antimicrobial use and consumption. And these are, for other resource-limited settings, these are resources that we're happy to share and happy to support other settings as they try to set up their AMS activities. Thank you very much. I will stop there.
Thank you so much, Dr. Ombajo. Some very interesting data. I have some interesting questions for you that we'll be discussing at the end of Dr. Ramsamy's presentation. With that, I'd like to invite Dr. Ramsamy to begin to share her slides. And once again, for everyone, Dr. Ombajo and Dr. Ramsamy will be back live on video. They're just reserving bandwidth and presenting their live presentation via their slides. Dr. Ramsamy, are you ready?
Yes, I am, Moni. Are
Excellent.
you able to?
Welcome.
Presentation. Thank you. All right. Okay, Moni, are we able to have a look at my screen?
Yes, we can see it.
Okay, perfect. Thank you. Good afternoon from KwaZulu-Natal, South Africa. It gives me great pleasure to address you all in this interactive platform provided by CIDRAP. Today, I'll be offering insights into optimizing our access and use of diagnostics for effective antimicrobial stewardship program implementation here in Africa, with emphasis on the situation in South Africa. So this is my disclosure statement. Antimicrobial resistance is a public threat, and it's a threat to global well-being. The burden of deaths and costs due to AMR is far-reaching. Arguably, the greatest risk to human health comes in the form of antibiotic-resistant bacteria. And as I mentioned, it is the next global challenge, and we need to act now, as the current estimates of deaths due to AMR each year is around 700,000, and that could reach millions by 2050 if not contained. And as far as the costs are concerned, if AMR is not contained between now and 2050, the estimated costs of addressing it would run into hundreds of trillions of dollars. So drawing an analogy with antimicrobial resistance and a phenomenon called load shedding, which is currently happening in South Africa. So for many years, South Africans have had the luxury of endless power supply, limitless energy to fuel our every needs, until recently, when we literally became powerless, succumbing to the concept of load shedding, which is stage-by-stage reduction in the availability and utilization of energy in South Africa, ranging from an hour to a few hours in the day. And in a similar manner with antimicrobial resistance, man has for many decades enjoyed what nature had offered us, an abundance of antimicrobials, modified and engineered into various classes to treat an array of infectious diseases. But slowly but surely, in a similar manner that we've experienced load shedding, we've got a situation where we've had beta-lactamases creep in the recent years that actually compromise our use of beta-lactams. So in stage 1, we were introduced to simple beta-lactamases that targeted penicillin and narrow-spectrum cephalosporins. In stage 2, we saw the entrance of extended-spectrum beta-lactamases, which limited our use of other antimicrobials in a broader class. And then in stage 3, which featured the AMC beta-lactamases, which then prompted the use of carbapenems. Now we've reached stage 4, where the carbapenemases run rampant globally, limiting the use of what we know as last resort antimicrobial agents. With very few newer agents in the pipeline, our very existence is threatened into a dark abyss. So this is a hypothetical infographic from a Lancet publication by Holmes et al. To illustrate the potential contribution of each factor as a driver of antimicrobial resistance, the supporting evidence for each, and the potential population affected, which is reflected by the diameter of each bubble. Factors were identified from a review of national and international AMR policy documents. And we can see or appreciate that the biggest drivers of AMR here can be somewhat overcome through modification of human behavior, with the highest drivers of AMR with evidence as identified as antibiotic use in animals and healthcare transmission, antimicrobial use in humans, and although low in evidence, suboptimal rapid diagnostics is seen as a high driver of AMR. So with regards to the challenges that's specific to South Africa, or that is specific to the African continent, we see that in Africa in general, from a systematic review that was published in the Journal of Global Antimicrobial Resistance, which looked at a WHO Global Survey looking at African countries that had adopted national action plans. And we see in the African continent that only 7 countries, namely Ghana, Kenya, Mozambique, Nigeria, South Africa, Tanzania, and Zimbabwe had reported having national action plans on AMR. And of the 7 countries with the national action plans on AMR, antimicrobial stewardship activities were identified only in 3 countries, which was Kenya, South Africa, and Tanzania. On a positive note, right? So whilst the continent faces a myriad of challenges impacting on effective healthcare delivery and implementation of antimicrobial stewardship programs, all included studies reported improvement in outcome measures, such as decrease in antibiotic consumption, compliance with antibiotic policy, and a reduction in surgical site infections following the antimicrobial stewardship interventions. So the conclusion of this article was that other African countries can emulate these examples. So with regards to antimicrobial resistance, and we see that with South Africa or with Africa, we see that the dying of the light happening with AMR, that time is running out. And with the time running out, we face a bleak future. However, with the steps that certain countries have shown, lighting the pathway in addressing AMR with antimicrobial stewardship programs that have been in place, we do believe that there is light, life, and hope. And some countries have provided a guiding light on strategies used to address AMR, and it's a path which the continent will take place. It's a path that many countries can adopt. And despite all the challenges that we face, we possibly can address AMR successfully. So WHO and South African strategies looking at the strategic objectives that address AMR. With regards to the South African AMR national strategy, this is an excerpt that has been taken, a One Health approach in accordance with the WHO Global Action Plan on AMR, which highlights the 5 strategic objectives, reflecting 1, a coordinated intersectorial effort involving human, animal, and the environmental sectors to address AMR in a One Health context. 2, diagnostic stewardship. 3, optimizing surveillance. 4, enhanced IPC efforts. And 5, appropriate use of antimicrobials in humans and animals through antimicrobial stewardship practices. So highlighted in strategic objective 2, to improve appropriate use of diagnostic investigations to identify pathogens and guide patient and animal treatment and antimicrobial management while strengthening quality laboratory systems for the detection of disease. So there is no doubt that South Africa's healthcare industry is one that is very dynamic, and our healthcare system is actually divided into a public sector healthcare system and a private sector healthcare system. And we see that currently the public sector provides healthcare for 80% of the population, and the private sector provides healthcare for 20% of the population. There is indeed a major gap between private and public healthcare in South Africa. Public healthcare is government funded, accessed by the majority. There are many disadvantages such as out-of-date facilities, long waiting times, poor quality of care, rushed appointments, limited resources such as staff and equipment, a lack of cutting-edge laboratory tests such as molecular diagnostic platforms, poor disease control and prevention practices. The private healthcare system or private healthcare is more expensive, It's not funded by the government, and there are fewer facilities with more resources that are available. So with regards to the diagnosis of infections performed by the laboratory, it essentially has three functions. So all over the world, the diagnosis of infections are predominantly there to, one, diagnose an infection in an individual patient for everyday management of infections, to advise on appropriate selection of empiric and directed therapy, and to support for infection prevention and control in ascertaining the source and root of transmission of healthcare-acquired infections. So in Africa, most microbiology labs use the classical or traditional methods of diagnosis. And as you can appreciate, a direct smear, culture, antigen detection, antimicrobial susceptibility testing, and antibody detection are some of the primary tests that we would do in a microbiology laboratory. With regards to molecular detection methods, those essentially are very few, and I will go on to discuss these a little later on. Okay, so diagnostics at our disposal on the African continent. So at the beginning of the 21st century, right, a high proportion of diagnostic tests are still being performed according to the methodologies pioneered by Pasteur at the end of the 19th century. And we can see that that's the case for laboratories in Africa and in South Africa, where in Block A, one can appreciate that this is essentially, or these are essentially the microbiological tests that are used in most of the laboratories. With the use of these tests, we can note that the time to result averages between 36 to 72 hours, which in fact is very long when compared to rapid diagnostic tests offering pathogen identification. In some cases, the identification of resistance genes in an hour with a 2-minute preparation time. There's still a high proportion of diagnostic tests within African laboratories that still, as I mentioned, use methodologies that were pioneered by Pasteur. So diagnostic technologies that are available in the South African public healthcare system. So if you look at this slide, there are different microbiological diagnostic systems that are used in the greater majority of laboratories in South Africa. The manual methods, such as agar dilution, disc diffusion, and e-tests are still used in many centers. There has, however, been a shift to automated diagnostic platforms, even in hospitals that are located out of the major cities. These platforms provide pathogen identification and susceptibility results. However, there's still a need for culture. These platforms interface with the laboratory information system, providing information from which pathogen surveillance reports are compiled by the clinical microbiologist. These then inform institutional specific antibiograms. So for example, if I've got a diagnostic platform in my laboratory and in the greater part of KZN, we're using the Vitek system. And what happens is once the interface takes place with the laboratory information system, we can actually draw out pathogen information data, such as pathogens that have been cultured and their relevant susceptibility patterns. And with that, antibiograms are formulated. And these antibiograms can be used within the institution, right, to display pathogen resistance trends. And they can also provide a regional picture of the area or a provincial picture of the area. And then these can be then compared to other provinces on a national scale. Also, an important thing about doing surveillance this way is that it actually would inform clinical guidelines within an institution to address various infectious diseases. So in essence, it's common knowledge that prompt initiation of antibiotics saves lives. So with such a delay in our turnaround times, using culture-based methods, are we able to make an impact in patient management and antibiotic stewardship in our setting? Loice et al. Demonstrated from a systematic review using odds ratios of studies in patients with bloodstream infections due to Klebsiella or E. coli, delayed appropriate therapy increases the risk of mortality, especially when appropriate treatment is delayed by more than 48 hours. So it homes in on the importance of appropriate therapy without delay, or initiating appropriate therapy without delay. So with this in mind, noting the urgency of instituting correct antibiotics and the diagnostics at our disposal, which require culture translating to longer turnaround times, the microbiology lab and the microbiologist play a pivotal role in antimicrobial stewardship and patient management. They're involved in accurate identification of the pathogen, rapid communication, in IPC interventions or infection control interventions, in education, the core of antimicrobial stewardship, looking at resistance surveillance and bringing the institution aware to microbiological alerts or alert organisms, managing outbreaks, and participating in healthcare-associated infection surveillance. So on this slide, we can appreciate what the microbiology lab actually does and what they can bring to the table as far as stewardship is concerned, especially in a setting where we don't have the luxury of rapid diagnostic tests. So the one important thing that's crucial in such a setting is communication. The clinical microbiologist and the clinician should not be worlds apart. And this relationship is critical in the appropriate management of critically ill patients with infectious diseases. In particular, the initiation of antimicrobial therapy, or where antimicrobial therapy is concerned. From specimen collection, meaning the type of specimen, right up until the process of processing the sample, up to the final report, there must be constant communication between these two entities, which makes a very big difference in patient management. So I'm just going to sort of give you a picture of how this is done at, as I call it, my hometown in Umlazi. Umlazi is a township located in the east coast of KwaZulu-Natal, South Africa. It's located to the southwest of Durban. It's the third largest township in South Africa after Soweto and Tembisa. So many of you may have heard of the town of Soweto. Umlazi is divided into 26 sections, A to Z, and it's home to over 500,000 people, where rates of unemployment and poverty still soar, like most other settlements in Africa. So Umlazi is not actually a settlement that's close to the city. It's a little bit more on the borders of what we would call or term a township. So I am the practicing microbiologist at Prince Masheni Hospital, which is located in Umlazi. And at Prince Masheni Hospital, a patient-centered multidisciplinary antimicrobial stewardship team has been established. The team consists of human resources that are at our disposal, who are considered to be the most crucial elements: the clinician, the clinical microbiologists, pharmacists, nurses, and infection prevention control practitioners, with the support of hospital management. We practice what we would like to call C5, right, which is continuous patient-centered care through communication and collaboration. So we don't really have the luxury of clinical pharmacists at our facility. Well, in most facilities in South Africa, that are public healthcare institutions, we don't have clinical pharmacists. So clinical pharmacists in an antimicrobial stewardship program here are essentially pharmacists that are trained and educated in the clinical and microbiological aspects of infectious diseases. So this diagram represents the flow of communication which occurs on a daily basis at Prince Masheni Hospital. Communication regarding the outcomes of step-by-step microbiological analysis is sent to the clinician, the pharmacy group, and the IPC group. The purpose of simultaneous communication is such that each essential component of the AMS team is aware of, for example, a critically ill patient in ICU who, for example, has cultured a multi-drug resistant organism from a blood culture requiring infection prevention and control precautions, and an antibiotic which requires a possible pre-approval, such as colistin. So the entire team, within a matter of minutes, will put all measures in place to ensure cohesive patient management. So once measures are instituted, continuous monitoring takes place. So one, the patient and the clinical response to the commencement of an appropriate and directed antimicrobial therapy is monitored, so how the patient is faring. Then there's monitoring of adherence to IPC measures and practices, including isolation. And the pharmacists monitor prescriptions. So looking at the adherence to prescriptions, looking at whether or not the clinician has prescribed the appropriate drug as per recommended by the microbiologist in the correct duration and the dose, avoiding polypharmacy. And all of this information is then inputted along with the laboratory reports. It's captured manually and then inputted into a data monitoring, into a database, which is monitored over time. And as our first speaker had mentioned, that initially there may be a little bit of resistance from clinicians about sort of, when pharmacists have a look at prescriptions and they would want to advise, or they possibly would want you to look at a dose or a duration. And that really happens at the initial phases of this. And then once the team is established and there's daily communication, it's amazing. It's amazing to note the actual compliance from clinicians in terms of taking advice, being open to having a conversation with the microbiologist and the pharmacist. It's just amazing how the communication and the collaboration enhances the antimicrobial stewardship team. So how can we make antimicrobial stewardship work in a setting such as ours? Well, the whole key to this is that it's important to make use of resources that are available and resources that are at your disposal. So from a clinical microbiologist, the rapid and constant communication is exceptionally important. And in the vast majority of hospitals in South Africa, and essentially in the most African countries, there's sadly a dearth of infectious diseases specialists and epidemiologists. So the clinical microbiologists who are based at the larger referral centers in the public healthcare sector, and their services impact positively towards antimicrobial stewardship, in that there is very meaningful engagement with clinicians, the infection prevention and control team, pharmacy, and nursing personnel. And this, as I said, happens during ward rounds. It happens on online platforms. And it's important in that the input from the clinical microbiologist regarding restricted antibiotic use, selective reporting, or what we like to call selective antibiotic reporting or releasing, and the restriction of antimicrobial use that is responsible or done in a responsible manner, along with the regular reporting of changing resistance patterns, is crucial in antimicrobial stewardship or in an antimicrobial stewardship program. So essentially, the microbiologist plays a pivotal role in confirming and managing outbreaks as well within a healthcare setting, and is also responsible for providing education to clinicians, pharmacists, nurses, and allied medical staff. With pharmacists, as I've mentioned, we need to empower pharmacists. And at our institution, that's what we do on a daily basis, along with sessions with pharmacists to empower them with the clinical aspects of infectious diseases management and microbiology. And infection prevention and control coordinator and nurses also play a pivotal role in that they're there to enforce correct IPC practices to all staff via the hospital IPC coordinator to limit the spread of healthcare-associated infections, educate nurses and other medical staff on the important role they play, and remembering at all times that knowledge is power. So when we look at this slide, we can appreciate the important role that a clinical microbiologist makes in such a setting. And the role of a clinical microbiologist in an antimicrobial stewardship program is invaluable, where there is no infectious diseases specialist or an epidemiologist that's present. So as we know, historically, clinical microbiologists perform laboratory investigations on blood, tissue, and other samples. They help to locate the infection, and they help to determine the correct antibiotic use and fight and prevent infectious diseases. And for a very long time, the clinical microbiologist was a behind the scenes personality, where we were generally in the laboratory, we handled reports, we sent out reports. But the current model of clinical microbiologist, as I would say, is one that is very dynamic, who's very visible, who's extremely involved and knowledgeable, who's engaging and irreplaceable. And these attributes enable the current clinical microbiologist to be a key player in the implementation and maintenance of an antimicrobial stewardship program at a healthcare institution. So I've touched on the methods or the microbiological diagnostic platforms that we have available to us in major parts of South Africa and in Africa. And I also wanted to speak about the role of rapid diagnostic tests in antimicrobial stewardship programs. There are currently no rapid diagnostic tests related to the management of antimicrobial resistance that are readily available for use in the South African public healthcare sector. The following platforms, however, are currently being evaluated within the National Health Laboratory Service. And when we have a look at it, we've got various platforms, and we're currently trying to establish how these platforms could fit in to our setting and make it suitable for use within a setting such as ours or in a low middle income country setting. So prior to the implementation of a rapid diagnostic test to address AMR in lower middle income countries, it's really, really important that, bearing in mind with the implementation of any strategy anywhere in the world, there are certain needs about the strategy which are to be fulfilled. There are certain aspects about the strategy requiring consideration and a review of possible risks of the strategy with possible solutions. The implementation of rapid diagnostic tests addressing AMR in low middle income countries is no different. So prior to the implementation, there's a definite need to demonstrate the utility and the performance of a rapid diagnostic test in antimicrobial stewardship programs within a lower middle income country setting. So we've seen various studies come out of the US and Europe and high income settings. And we've seen its use there and how it's improved antimicrobial stewardship. But we need to demonstrate it in our setting. We need to perform the evaluations of rapid diagnostic tests in clinical studies, as evaluations that are laboratory-based are insufficient. So it's very important to interpret these tests in collaboration with clinical findings, and that is crucial. There's also a need to evaluate the cost, the feasibility, and the practicality of implementation of rapid diagnostic tests in a lower middle income country setting. Is it affordable to us? Is it sustainable in such a setting? With regards to the considerations, are these tests likely to have the same impact in a lower middle income settings, such as the ones that have been demonstrated in high income countries? Would this lead to inappropriate test use, increased cost without patient benefit? And we need to consider, before implementation, is there an established antimicrobial stewardship program in place at that hospital, right? Because the possible risk is that rapid diagnostic tests, when used without proper interpretation, may be prone to misuse and overuse as are antimicrobials. So ideally, it's really important that prior to the implementation of a rapid diagnostic test within a lower middle income country setting, it's important to lay out guidelines and protocols on how these need to be run and interpreted. It's also important that these tests be available or situated in laboratories that are 24 hours, in laboratories that already have the services of a full-time clinical microbiologist, because the interpretation of that test and the communication that's sent out to the clinician is vital. So the antimicrobial, with regards to antimicrobial resistance, antimicrobial stewardship, we now see that the microbiology lab plays a pivotal role in our fight against AMR. The crisis of antimicrobial resistance has resulted, and this is a quotation that has been taken out of a recent publication by Morency Potvin et al. And I'm just going to read you an excerpt on it. The crisis of antimicrobial resistance has resulted in the need to optimize clinical infection management, manifested by the widespread emergence of antimicrobial stewardship programs and the recent proliferation of innovative rapid diagnostic methods. Rapid diagnostic tests accompanied by their attendant uncertainties with respect to instrument selection, cost, performance characteristics, deployment and workflow, interpretive guidance, and rapid technological turnover could boost the clinical relevance of clinical microbiologists to levels unseen since the time of Koch and Pasteur. So we see that the microbiology lab plays a pivotal role in addressing AMR. And I think going forward, even with consideration of rapid diagnostic tests, we really need to have access to these tests that actually show that they can work in settings such as ours, lower middle income country settings such as those in Africa. So in conclusion, antimicrobial stewardship in Africa is possible. Key to its success lies in the utilization of available resources coupled with commitment and a passion for health system strengthening. The need for research and development of microbiological tests used in a diagnosis of infections that are suitable and sustainable in an African landscape cannot be overemphasized. I would like to thank you all for your attention and thank you for your support. I would like to thank CIDRAP again for the invitation to speak on such a platform. And before concluding, I would like to extend the following acknowledgements. Thank you.
Thank you, Dr. Ramsamy, for the overview and the perspective. I'd like to invite back Dr. Ombajo to your camera. Okay, excellent. And if you can just go off mute to begin the question and answer session. And I just wanted to, all of our participants that are on today live, Please submit any questions or comments you have via the chat box as well so we can address them. We've got 15 minutes for question and answers. I want to start with you, Dr. Ombajo. Can you, as the infectious diseases consultant, physician consultant, your role that you play as part of this interplay between the diagnostic laboratory, stewardship, and infection control, just to give us a clear picture of the different hats that you wear.
Okay, so thank you very much. So my primary role is in clinical care of patients. So often we'll have infectious disease consults from the Kenyatta National Hospital where we work, or from other hospitals in the area. And questions are usually around patients who have been on antibiotics and don't seem to be doing well, or in whom some organism has been cultured and people are wondering, what do we do about this organism? Do we need to add on another antibiotic? Or patients who've had so many add-on antibiotics but don't seem to be doing well. And often in reviewing these patients, that's sort of where now the other hats come in. In reviewing these patients, many times you find that the antibiotic was never indicated in the first place, or the patient has had antibiotic combinations that were not appropriate, or the clinician has been treating colonization or contamination rather than actual infection, or we're not thinking about certain pharmacokinetic and pharmacodynamic principles in the treatment of patients. So with that then comes the issue of how do we build capacity of clinicians and of the lab and of the IPC to manage patients appropriately. So one, if we start with the issues of the lab, as I said, many times you end up with either patient has not had samples taken, or the wrong samples have been taken or not taken correctly. So you're ending up growing a lot of colonizers and contaminants, which we then treat. So there comes the issue of diagnostic stewardship. How do we talk to clinicians about when and how to order samples, order laboratory tests, how to collect those samples, how to transport them to the lab, and how to interpret them when they come back. And then working with the lab to say, in order to support stewardship, what reports should we give and what should we not give? So for example, you may find labs that will release samples with a coagulase negative stuff that's grown from one bottle. So to talk to the lab and say, when you have that, that shouldn't be reported, because not all labs have a clinical microbiologist. Many times it's lab technicians handling this. And also that if you grow something that doesn't seem to make sense, can you reach out to the clinical team so that you discuss it and determine what reports should go out? Or from a stewardship perspective, if you have a susceptible organism, so if you have maybe an E. coli that's susceptible to second and third generation cephalosporins, can we consider not releasing the report for carbapenems, for example, just because many clinicians, when they look at the report and they say meropenem MIC less than 0.05, and ceftriaxone MIC 4, they want to go for the, the lower MIC without understanding that ceftriaxone will work just fine. So it's really working with clinicians to improve that understanding, improve issues around diagnostic stewardship, and working with the lab as well, so that they are partners with the clinical team, as opposed to two teams working in parallel. So how do we bring them together? And situations where we have identified resistant organisms, then now the IPC has to come in for issues around containment and prevention of outbreaks. And like some of the examples that I shared, where we noted outbreaks in a unit, to control an outbreak requires a very multidisciplinary approach, where IPC is really in the center of it, but lab also support and clinicians do their part. So again, MS is never a one person's journey. In doing MS, we really have to work with the clinical teams, the lab teams, the IPC teams, and the pharmacy teams.
Thank you. Yeah, I wanted just more understanding of all the different roles that you played in the execution of stewardship and diagnostics, because it's so, and then you mentioned the importance of infection control. And I have some specific questions around what you've presented that I'll get back to. Dr. Ramsamy, you presented very well the role of the clinical microbiology lab and how it really sits in the center of, you've got to have data to then make clinical decisions. and do these evaluations. I'm curious, as you're starting to evaluate the rapid diagnostic tools to try to shift perhaps the accuracy or the lower the time to correct antimicrobial prescribing, how are you connecting, as you said, it has to be sustainable, it has to have utility, the clinical endpoints? What's your strategy for outcomes there, connecting the test with the clinical performance?
So essentially with the rapid diagnostic tests that are being evaluated at the moment, they're actually being evaluated in collaboration with the clinicians in a clinical setting. Because if you are just going to purely do it from a lab evaluation, it's definitely not going to show any promise or highlight anything. So most of the evaluations that are currently being done is done with a clinical team as well. And in that you are now doing a comparison with starting or instituting correct antimicrobial therapy. Like for example, if you've got a rapid diagnostic test that has just an identification of a pathogen and not necessarily antimicrobial susceptibility pattern, from a clinical micro perspective, you need to have known your surveillance pattern already. So if you identify, example, an E. coli in your neonatal nursery on a rapid diagnostic platform, it's important that you know your surveillance and what you're sitting with in nursery. And then you would be able to tell the clinician, hi, I've got this on your platform in the laboratory from the blood culture that was sent to me. And looking back at our susceptibility trends over the last 6 months, our E. coli's are generally susceptible to ciprofloxacin or piperacillin tazobactam. And empirically, I think we should go for this. So in that respect, now you are making a decision with the clinician based on a result that you obtained from a rapid diagnostic tool that you've used, but it's also based on surveillance and your information gathered from there, because you don't want to, it's now instituting empiric therapy that is based on some evidence that you've got behind you. And then whilst you wait for the culture and your susceptibility to come out in the next 24 hours, you would have already started empiric therapy that is based on some sort of evidence.
Yeah, that's a very important point. And to follow up with that, Dr. Ombajo, you mentioned that initially there was this inferred understanding, or at least a misperception, that you had a lot of multi-drug resistant Klebsiella pneumoniae. And so people were prescribing, wanting to go to meropenem initially. And you mentioned that it could be around sampling, bias around the sampling, where those samples that were actually being obtained are perhaps somebody that wasn't performing well on their initial antibiotics. They go to laboratory, and now these are the resistance one. And now there's this perception that you have more resistance than you really do. How did you address that?
So one of the problems we've had, especially with developing antibiograms, is that when people fail to take samples for all patients as appropriate, so we don't take enough samples for patients who come from the community. We do not take enough outpatient samples. We do not take samples for patients who are doing well. We only take samples from those patients who are in critical care unit or who have failed to respond to the initial antibiotic. And basically what that does is that it skews our data towards a resistance profile, because it really is representative only of patients who've had significant antibiotic exposure, as opposed to the overall population that we have in the hospital. So one of the ways of addressing this is, again, going back to the issues around diagnostic stewardship. When should we collect samples? So, and then how do we analyze our antibiogram so that if it's critical care, it's not lumped up with the rest of the hospital? Because if that happens, then you end up with a fairly resistant pattern for a unit that generally takes care of patients without significant healthcare exposure. So one is really just around talking to clinicians, training clinicians and enabling clinicians to be able to take samples or request for tests at the right time for all the patients. And then working with the lab around how do we analyze the results that we have so that our antibiograms are representative of the populations that give the samples. So that's one. When we have antibiograms that only look at ICU patients, we'll see a lot more resistance in ICU than in a general ward. And if you use that in a general ward, then we'll start, with broader spectrum first line agents as opposed to what we should. So a lot of it comes back to ensuring proper diagnostic stewardship. It's really, really key. And it's an area in which we have not done too well. So when, for example, we have an ICU context, for example, where we have an outbreak of Klebsiella in an ICU or in a neonatal unit, one is containment, so reduce spread for one. Then going back to look at what are the risk factors. So studying the patient populations clearly to understand the procedures, the invasives, the antibiotic exposure, so that once we understand the risk factors, then we can begin to work on some of those. So one just around IPC, around simple things like removing urinary catheters in good time rather than leaving them hanging in there for a long time, changing lines appropriately, and then of course reducing unnecessary antibiotic exposure.
Dr. Ramsamy, I would ask you the same question. I've heard this brought up on other presentations, different areas of the, it's globally as far as what samples you collect and do you get sample bias and how much antimicrobial resistance do you have? So you need to get a baseline. And then as you make your implementations, as Dr. Ombajo showed, she had 2017 to 2019 data. You're then able to track those changes over time.
Yes, and it's definitely, because also it's important, and I think most clinical microbiologists do this. When you're drawing up your antibiograms, you would have different antibiograms for different areas of the hospital. So my ICU antibiogram is not going to look like, an antibiogram that I would tell clinicians, who are looking at patients in an outpatient setting where majority of the patients present with, say, for instance, a urinary tract infection. So I think it's really, really important that you kind of get a picture of a specific unit and their inherent flora and what that inherent flora is susceptible to institute antibiotic therapy empirically for that particular unit. So as Dr. Loice said, I am not going to recommend the same antimicrobial agents for a patient in ICU with a catheter-related infection or urinary catheter-related infection versus someone who's now in the outpatient, because I've got different antibiograms and different flora and different resistance trends for those specific areas of the hospital. And it definitely is a lot of work, if I can use that term, to actually basically sort of categorize different areas of the hospital, different patient populations. But if we were to do this successfully, that's the only way to actually do it. Because then if you're going to infer all of your ICU data to the rest of the hospital, then you're going to be starting a carbapenem on many patients. So, so it's very important to note outpatient versus inpatient, or patients that are coming into a clinic or medical outpatients clinic versus a neonatal ICU. So it's really important because there's inherent flora, inherent organisms, inherent antimicrobial resistance patterns for specific areas.
That's a very good point. Depending on your unit, both of you presented that. With the few short amount of time we have left, if I'm looking at the questions that have been submitted, I really want to switch towards education and accessibility to antibiotics, and that being outside of the hospital, but more of an outpatient setting, where people have access to antibiotics. Your role and involvement in education around that, so that you're restricting basically access to some of these antibiotics, so then you don't end up dealing with the severe infection in the hospital. Dr. Ombajo, are you involved with some of your the clinicians that might be more in the outpatient setting and accessibility to these antimicrobials?
So I think outpatient antibiotic use for us is a big problem. And I think I've noted a few comments on that as well in the chat.
Yeah.
In Kenya, for example, even though there's policy around restricting outpatient antibiotic dispensing or community dispensing of antibiotics, it's not really enforced, which means somebody can walk into a community pharmacy and pick up an antibiotic. You know, somebody can go in and describe to a pharmaceutical technician that, you know, I have a cough, I have a sore throat, and they'll go out with an antibiotic, or really just go there and ask for an antibiotic and they will get it. So that's one of the biggest challenges we have in antimicrobial stewardship. And basically what that means is that anyone who comes into hospital has probably already been exposed to an antibiotic. In some of our surveys in the hospital, we find that about 30% of the patients coming in have already had an antibiotic self-prescribed. And this problem has become even more pronounced in the context of the COVID-19 pandemic. There's been conflicting data about the possible role of some antibiotics like azithromycin, for example, especially early on in the outbreak. So we've had a lot of outpatient self-prescription as well as, you know, community dispensing of antibiotics, which is a challenge. We are trying to work with our regulatory authority, we call that the Poisons and Pharmacy Board, to put in place measures for better regulation and better control of, you know, out of the hospital antibiotic use. And it's interesting, sometimes people get antibiotics and they get better, so they keep it. And the next person who feels a little ill is given 2 or 3 pills of the last antibiotic the last person got. And there could be a bag of antibiotics that's shared around over the next 10 or so years, you know. And really, in terms of generating community resistance, that's the perfect way to do it. So it's a challenge that we have need to get over. We are hoping that slowly, as we work with the regulatory authorities, we could get to a place where there's less of self-prescribing or community prescribing of antibiotics.
Yeah, really part of the national plan for restricting antibiotics and antimicrobial stewardship. Dr. Ramsamy, we just have a few more moments here, but I thought I'd like to hear your perspective as well.
Just drawing from my personal experience on the education and aspect and the prescribing of antibiotics, what I have done at the hospital is we've had departmental meetings. For example, the Department of Medicine, myself with all of their doctors, meaning from their consultants to their interns. What I do is I show them presentations on, this is your department. These are the different infections. These are the different infection rates. And these are the organisms that we've cultured. And these are the susceptibility patterns. So what happens is that it then sort of is an eye-opener to them about, for example, if we're looking at a urinary tract infection in patients who are from medical outpatients department, contrary to what maybe our national guidelines may say about instituting drug A for a UTI in a patient who presents with a UTI, I've done, well, not the opposite, but I've showed them evidence that in our area and in our setting, this is the commonest cause of the UTI that we see in the majority of our patients. And 80% of those pathogens are susceptible to drug X. And drug X is of a lower spectrum. So in that way, you kind of highlight to the clinicians with evidence that, look, for your patients who are seen as outpatients, this is exactly the infections I'm seeing, and this is the evidence for it. And as I said, it is a lot of effort and it requires teamwork, but I find over time, it makes life a little bit easier in terms of when you start engaging with clinicians again regarding, you know, the use of certain antibiotics and certain antimicrobial categories. So therefore, it's so important for a clinical microbiologist to establish with the institution and all their colleagues that this is now what's inherent at our institution. And this is the best sort of guideline for our institution. And it's very important to highlight that, because something that's done nationally may not be applicable to your institution, and you may be able to further narrow the spectrum of antibiotics that are being used.
Absolutely. Yeah. It just shows the importance of having the data from the clinical microbiology lab to support the clinicians in the decision making. And then of course your conversations with the policymakers. I'm going to get to the attendance code here. I just wanted to take a moment just to thank Dr. Ombajo and Dr. Ramsamy. Your time is very precious, and let everybody know that listened to them today from their perspective and their experiences and their knowledge that they have in this area. They're very busy and they worked very hard to bring this presentation to you. And we look forward to more information coming from you as you continue with your programs and your efforts. And for those of you that listen that want to collect your CE, there's the website again at proce.com, and your attendance code is 94HAVX. So you'll need that to collect your CE credits for 1.25 hours. Dr. Ramsey, Dr. Ombajo, thank you so much for being a part of our global outreach for antimicrobial stewardship and diagnostics. And we thank our supporter, bioMérieux. Very, very terrific presentations, and appreciate your time this evening.
Thank you.
Thank you.
Bye, everybody.
Bye.